I guess looking at the cases and questions that were sent, there are some reasonably predictable themes. And again, my disclaimer from this morning, I don't pretend to have all the answers, I just do the best I can. I won't embarrass the people by reading out their names or whatever, but just going through the topics that I sort of picked up on, a very good question I felt, and something that I see a lot, is, and we touched on it this morning, is people who are on proton pump inhibitors. And often it's not very clear when or why they were started, and hence it can be not very clear if and how they can be stopped. And I guess a common scenario that I see in my practice is someone who's maybe been put on aspirin and has been put on a proton pump inhibitor just because they're on aspirin, and then sometime later, a very conscientious prescriber, be it the nurse practitioner or the GP or a junior doctor or even me, will come along and have a discussion with the patient and stop the aspirin, but doesn't think to stop the proton pump inhibitor. And I guess that's something that you probably see as well. We start a lot of proton pump inhibitors in hospital, I'm very aware of that. If it's given for the treatment of gastroesophageal reflux disease, the guidelines do suggest that you give 4 weeks and then stop it and see what happens. And then a lot of people, I can't give you an exact figure I'm afraid, but I know, a number of people will then get resurgence of dyspepsia, and they may end up back on a proton pump inhibitor. Ideally, it should be in a lower maintenance dose. So, I think if you've got a patient who may have come under your care from from having been under someone else, it may not be clear why they've started on the proton pump inhibitor. They may not be very clear about it. In fact, they often aren't, of course. My advice on that is to follow Fiona's tip, is, if you can, reduce it. If you can reduce it more. And if you can reduce it more, stop it and see what happens. If you've got someone who, after discussion, you feel and they feel, or you negotiate and you come to an understanding that maybe that person should stay on aspirin. Not everyone who's on aspirin needs to be on a proton pump inhibitor. Generally, you would want to limit the dual prescription, as it were, to people who've actually had previous dyspepsia. So I wouldn't let the fact that someone's on aspirin be the only thing that makes you leave them on a PPI. If there's no clear history of previous harm or gastroesophageal reflux disease, I would still reduce and maybe think about stopping the PPI. Does anyone want to comment?
It would be great if there was coding on medtech that allowed you to show medicines which are intended for a short term in a different colour.
Yeah.
I mean, you get a highlighted medicine come through now for hospital prescribes, and we do it in the house anyway. The top roll, 47.5, comes through as a bolded medicine. So it looks quite distinct in the column. But if you had a green appearing medicine that you knew you were only going to give it 3 months, or that you had to change the dose of in 3 months.
I think as we move into a national system for electronic prescribing, hopefully those safeguards will start to be built in. I came from the UK and was used to working with a particular electronic prescribing system that was actually, there were aspects of it that were cumbersome to use, but what doctors, including myself, liked about it was kind of a bit of a nanny for us, because it would actually not let you do stupid things. It wouldn't let you prescribe super normal doses. If you were trying to prescribe something like an antibiotic, it would make you put a finish date. And would highlight interactions. So, where we are perhaps in hospital starting someone on a PPI and the goal is for them to be on it for 4 weeks, stop and review, that could then be inbuilt into that prescription. So Yeah, I agree with you. I think having electronic tools to help us is definitely the future. Yeah. Does anyone want to comment about proton pump inhibitors or any cases that you've had that?
To say that in practice we do see quite a lot of people that get rebound hyperacidity. So when we do try and taper, they'll come back and just say, I can't take this. And that's because suddenly they've got a whole lot of overexpressed acid pumps churning out acid full stop, like full on. And we use quite a lot of tapering, but with PRN. So they're on 40 milligrams twice a day. We drop them down to 40 milligrams once a day. We'll often taper that by doing it 20 twice a day, and then giving them an extra PRN dose to use if they do feel like they aren't coping with the rebound. So those are sort of the little tips that have worked to get people, if not off them at least. Often they'll get down to PRN use, and then they can just use a PRN dose every third day or when they have a bout.
And I guess as well, we should remember the other alternatives. In older people, I see an awful lot of hyponatremia, and as I lecture to my juniors incessantly, the two commonest causes of hyponatremia in the elderly are infection and drugs. It's as simple as that. Yes, there's all manner of fancy metabolic mechanisms that we learned about way back when, but at my simplistic level, it's infection and drugs. So you look for infection and then you look at the drugs. And a lot of doctors don't realise that PPIs cause hyponatremia. And people can be quite ill as a result of that. They can feel quite unwell. So, remember there are alternatives. We can use H2 antagonists, which we tend to forget about now because PPI superseded them. But when they came out, everyone thought they were wonderful. And for some people, they still are wonderful.
Well, just the co-prescribing with SSRIs is remarkably common in breast age. The correlation with that hyponatremia is spectacularly common.
Yeah, I see people on, frusemide, ACE inhibitors, omeprazole, SSRIs, and then you think, whoa, pick one. So that was a very good question. Thank you for that one.
Was there anything to do with the NHS Cumbria stop-start guidelines? Or?
Was there anything to do with them? No, I'm aware of them.
Okay, because I mean, that would be one of the starts is not SSRI, proton pump inhibitor with a non-steroidal. Of course, it doesn't mean aspirin as such. It means.
Yeah.
But I mean, you have to go back to think, well, what is the reason for giving the anti-inflammatory?
Oh,
that
absolutely.
That be the shortest course probable, and then stop the concomitant PPI when you've stopped the anti-inflammatory. But it's quite good that it's not all.
Not all pain is inflammatory.
Yeah, true.
And I see. I mean, we're all aware that particularly in older people, the risks of non-steroidals are not just gastrointestinal; it's also renal. And I see people who are absolutely welded to their non-steroidal anti-inflammatories and believe they cannot live and function without them. But again, with careful negotiation and discussion, often you can work with people and again really properly assess their pain and if it's not inflammatory, there shouldn't really be any benefit to an anti-inflammatory drug, and there are other safer options usually. So, but I do see people who just refuse to stop taking them. People who've already got renal impairment, but
What would be your favourite alternative to non-steroids in people with osteoarthritis?
You think about the individual, but I like the whole idea of the analgesic ladder. So I do use paracetamol. Generally I would advise people in the first instance, if there's a pattern to their pain, they might be able to take it PRN. If it's a chronic pain, I do sometimes advise them to take it regularly. What the evidence suggests to us is that a lot of people will tell you paracetamol is useless, doesn't take my pain away. But the research suggests that it reduces the need for other painkillers significantly. So, you know, and if you tell people that, you say, okay, the paracetamol may not fully take away your pain, but then there are other things we can add to it, but you will hopefully need less of those other things. And then you know, obviously the Analgesic Ladder, I do use opiates in the elderly. I use them as sparingly as I can. Fiona will often tell me, why are you using oxynorm and not morphine? And, you know, as we were saying earlier, I've yet to meet anyone who's genuinely allergic to morphine, but my anecdotal experience is that people have more adverse effects with it than with oxycodone. I have some experience of using fentanyl. I use it in people with renal impairment, and I try and avoid tramadol, and most of all is avoid using combinations. I know that pain specialists and I know that anaesthetists use opiates in combination, and I'm not saying they're wrong. I'm just saying in the clientele that I work with, my experience is that if you give people particularly tramadol and another opioid, the adverse effect profile it jumps up a level. I've had patients who've literally lost days of their lives to combinations of opiates where they've been so out of it that they don't remember entire days happening. I do use neurogenic pain relief. I use nortriptyline in small doses and gabapentin. I always start low and go slow. That's the mantra for all geriatricians possible. We start low, we go slow. Gabapentin, you know, when it tends to traditionally get prescribed 3 times a day. I do have patients where their pain pattern is such that I've tried them with it once or twice a day and they do quite well. So, you know, you don't necessarily have to give everything in the doses that we first think of. Pain colleague, did you want to comment?
Well, imaging gabapentin, it's got about a number needed to treat of 1 in 8. So 7 not going to get any relief. And then in neurogenic pain meds, only about 30% get 50% reduction. So you've got 70% that probably get no relief from neurogenic pain meds.
And I think that's why we have to follow these people and monitor the effects of what we do and not just keep throwing more at them. The other thing to remember, particularly managing chronic pain in older people, you're very rarely aiming to totally relieve their pain. And, you know, what we're hoping to do is get people's pain to a level that they can tolerate it, not make it go away completely.
I mean, probably the biggest thing I can say is to look at the non-medical strategies.
Yes, absolutely. That's so important.
You know, it's not just about medicine. And so at Hunter Integrated Pain Clinic, they've turned the biopsychosocial model around. So they have a social psycho-bio model, right? And just to emphasize, you know, if you've got an elderly person, well then meaning in their life might be more important, you know, than just a little pill. So.
Absolutely. Yeah. Okay, so another interesting case that was given to me. Now there isn't specifically a question attached to this, but it's a case of an 82-year-old patient with lots of comorbidities, so COPD, previous cataract surgery, peripheral neuropathy. It's a male, I'm guessing, because they've had prostate cancer. They don't drink, they've had some skin lesions, they've had cataract surgery, they wear hearing aids. They're on warfarin for atrial fibrillation, they have ischemic heart disease, and have also had previous TIAs. They've had a previous resection of a pancreatic adenoma, they have BPH and have had a TURP and a background of rheumatic fever, and they're on 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 21 drugs. The bit that stuck out for me that I thought was probably interesting to discuss is the anticoagulation in AF. And in fact, another person emailed a similar question. This very week, I have seen a man who is in his 80s. He has relatively advanced dementia. He has care needs that could no longer be met in his own home, and he lives in secure dementia care. He's been deemed incompetent. He has a son who is very caring and is his enacted EPOA. He came into hospital having had a fall with a fractured neck of femur. He has a background of AF. He's on warfarin. His surgery had to be delayed while the warfarin was reversed. And initially, before I was involved with his care, he was being given tiny doses of vitamin K to reverse the warfarin on the premise that following his surgery, he would be put back on the warfarin. The delay in the surgery meant we had this poor elderly demented man, effectively bedbound with traction, becoming more and more delirious on top of his dementia, at risk of all the things that go along with immobility, infection, etc., etc. And then I came along to do my orthogeriatric liaison bit and said, well, I don't think you should go back on warfarin. And in fact, when I talked to the family, this was not this man's first fall. So he, had been falling for some time. And again, I was in this very interesting situation of having the discussion with the son of, the warfarin has to be reversed to allow the surgery to happen, and I'd like to discuss with you that maybe not going back on it is the right thing to do at this stage. To which the son said he was told he'd be on it forever. And so we had a very good discussion, at least I hope it was a good discussion, about risks and benefits, and the son clearly grasped that when this man was started on the warfarin, undoubtedly the benefits outweighed the risks. Now that's not true. And we were able to come to a good understanding and say, yes, there is a risk of him having a stroke. But at the moment, the greater risk appears to be the fact that he's having multiple falls, he's sustained a fracture. Fractured hips bleed a lot, so he's already lost a lot of blood. So the whole question of anticoagulation in AF, I think, is one that we see time and time again, and now we've got the novel anticoagulants, which make it more complicated. I think all you can do in any situation when you're with a patient is keep thinking about that. What are the risks? What are the benefits? And given this person's situation now, do the benefits outweigh the risks, or do the risks outweigh the benefits? Increasingly, the evidence suggests that antiplatelet agents don't have a role in AF. So if we're not going to put people on warfarin or dabigatran, sometimes, and I think we do it to treat ourselves, what we have done is said, well, we'll put them on a bit of aspirin instead. And previously there was perhaps a bit of evidence to support that, but increasingly that's looking not the case. So again, I'm sure this is something most of you must have come across.
In this case, the guy also had TIA, right? Is that
This one here, yeah.
So I think one, I don't know if that was not my case, but I had a question about anticoags and antiplatelets because people get discharged on that. And when they've had either peripheral, the recent one I had was peripheral vascular disease was the justification for aspirin, but also had AF. So they go on both.
Yeah. It's hard, isn't it? Because, the evidence is not that robust.
For which one?
Well, for the combination.
Okay.
And they're being given for different indications, aren't they? But what we do know is the risk of bleeding is much higher if people are on both. And, if you've got someone who's, relatively, the risks do increase with age. The risks of anticoagulation definitely increase with age. Whereas the benefits don't really change much. So what tends to happen is the benefits do this, but the risks do this. And they cross at some point. I mean, where you can, I think what you have to do is have the discussion with the patient and find out what matters to them and what their concerns are. You know, if someone's, again, if their fear of having a further stroke or a severe stroke outweighs their risk of bleeding, they may accept staying on dual therapy. I would be uncomfortable with that, but that's, you know, got to have those conversations.
And then sometimes communicate it to all the other doctors and go back to hospital.
Yeah, I mean, that's the difficulty again, you know, with having different systems in primary care and secondary care, isn't it? You know, it would be nice if we all used the same records. I think, again, there are moves towards that.
But with IF and anticoagulants, you know, you've got your TERT score and you've got your
and
So that's something that you can discuss with the patient. And if your bleeding risk outweighs your stroke risk, well,
and increasingly, I think we will have these tools. You were asking earlier about, you know, resources that help us to inform patients about the relative risks, and Jane has given us some references to various resources, and you know, that's very useful. As I'm sure you know, Up to Date do have patient advice. I find it quite wordy. I often refer to a website called thennt.com. It's not perfect, but I find it's not aimed at patients, it's aimed at healthcare professionals, but it gives you that little bit of background numbers to be able to say, you know, this is how many people have to take this medication before one gets any benefit. And of course, as you know, in alongside the NNT, there's the NNH, which is the number needed to harm. And again, you know, that can be as high or higher. So, yeah, I have again, you know, this is a bias of the patients that I see, but I have probably quite a low threshold for stopping anticoagulation in older people. If they're on lots of medications or there's history of falls, people who don't, you know, people perhaps with visual impairment struggle with warfarin because there's, you know, different doses, different combinations of pills to make up the dose that they're on. Along the way, as with everything, communication, you just have to keep talking to the person, or if they're not, you know, perhaps competent themselves, their family, and keep weighing up, you know, what's important to that person, what their goals are, what their targets of therapy are, really. So that was another good one. I feel like an agony aunt. It's quite exciting. What else have we got? I've already, Oh, statins. I guess we have to talk about statins, don't we? All keep saying, and of course there's statins. Yes, again, I probably have quite a low threshold for stopping statins in my patients. It is increasingly controversial. The whole history of how statins came to be developed is quite fascinating, and the evidence is largely driven by big pharma. You know, someone asked me the question recently, if your GP tried to start you on a statin tomorrow, would you take it? And my answer was, I don't even let my GP check my cholesterol. Because I have no other vascular risk factors, so why would I? You know, you know, primary prevention, secondary prevention, obviously the data is different. Most of the data is in men. The outcome measures are all different. You know, what do we know about statins? They make some numbers go lower. That may or may not have a benefit. They may work completely differently through a totally different mechanism. It's all very vexing, really. I look at it, again, I'm, you know, very simplistic, really. I look at it with the kind of patients I see. I have the conversation with them. It never makes them feel better, ever. I've never met anybody yet who says they feel better on a statin. And generally, quite a lot of them, it makes them feel worse, and they're often happy to come off it. I have had one remarkably well 95-year-old man who chose to stay on his statin. He felt it was doing him no harm at all, and on the basis that it might just prevent something, he was happy to keep taking it, and that's fine. but he was informed. So, you know, I think we just keep plugging away at that. My mother was put on a statin by her GP at the age of 83. She had not had a vascular event ever. She was mightily dischuffed at being told she couldn't have grapefruit, and she felt dreadful on the statin, and she rang me, and she rarely discussed her healthcare with me. In fact, she used to encourage me not to let people know I was a doctor for some reason. And, you know, and I said to her, well, don't take it then. Oh, the doctor says I must. I said, you know, if I told you must do something, you'd tell me to take a running jump. You know, it's different. I'm the daughter, not the doctor. But no, she came off it and she felt much better off it, and she lived another 5 years. So, yeah. And she had the grapefruit, yeah, you know, which probably did her more good, I suspect.
But I think you've got to look at your patient. And I mean, I'm cardiac based, so I'm struggling a little bit with this. So not in an 80-year-old, but you know, when you've got your 60-year-old that's had his event and stented and all the rest of it.
Oh yeah.
It is that risk water again. And,
yeah, absolutely.
And your patient, so.
Absolutely. And you know, a 60-year-old who's had a vascular event, if there's no contraindication, I would certainly discuss with them about going on a statin, and I would give them, you know, advice about what the side effects might be to look out for. The one that's most underreported in older people is definitely the muscle pain. But yeah, you know, an otherwise good 60-year-old, there's no reason not to. Yeah.